So I'd like to introduce Dr. Habash to everyone today. She was named to Castle Connolly's Elite America's Top Doctors list for 2015, which represents the top 1% of physicians in the nation. She began a successful career as the elected president of the Palm Beach County Ophthalmology Society and gained further acclaim after the state's Florida Society of Ophthalmology named her Young Ophthalmologist of the Year for demonstrating leadership, service, competence, and devotion to the highest ethical and professional standards. She was then asked to serve as a board member and president of the FSO, the governing body for all ophthalmologists in the state of Florida. Dr. Habash was recently appointed to join the faculty of Bascom Palmer Eye Institute, the top eye hospital in the country, and as a fun aside, she is the official eye surgeon for the UFC organization, providing surgical and trauma care for the MMA fight champions. Okay, before we have Dr. Habash start her presentation, I'd like to run a poll question by everyone, and I'm going to launch it in just a second. Okay, so the poll question, which you should see on your screen and be able to vote for, is do you currently use telemedicine? We'll be running this for just a few seconds. We're already getting interesting results. I'm going to run it for about 5 more seconds, and then we're going to go to our second poll question. So I'm going to close it now and share the results. So interestingly, 59% of you do use telemedicine, so I'm going to assume that the other 41% are interested in having that come into part of your practice. And then we're going to go right into our second poll, which is, have you been billing for telemedicine? So if you could answer that question, and we'll run this for a few more seconds. Thank you, everybody, for voting. It really makes a difference in helping to tailor the webinar to you. I'm going to close that poll now and share the results. So only 33% of you have been billing for telemedicine. So I'm assuming, Dr. Habash, you're going to get a lot of questions today on the process and the procedures for that. So at this point, I'm going to close the poll, and Dr. Habash, whenever you're ready, you can start.
Hi, everybody. Well, this is Dr. Ranya Habash. Thank you so much, Lisa, for the introduction and for getting all this set up for us. I believe we're going to have an excellent session today and go over a lot of different things. But I wanted to start off with one very interesting thing, and that is kind of where telemedicine got its start. And everyone thinks this is a relatively new concept, but it's not. It's been around for a very, very long time. In fact, smoke signals were the very first, and earliest use of telemedicine. African villagers used to use smoke signals to warn others to stay away whenever there was a serious or infectious disease ravaging their villages. This was a very common practice among African tribes. A little bit more recently, of course, in 1924, radio news predicted that doctors would one day be able to treat patients by picture. And telemedicine first appeared in the medical literature in the 1950s. One of the biggest users of telemedicine is actually prisons. Prisons have used telemedicine very heavily since about the early 2000s. And this is really important, actually, because prisons have done more than 9,000 telehealth consults in 2004 alone. And that saved, there was actually a study done about this, but that saved the taxpayers $4 million in transportation and escort costs. At Bascom Palmer, we have a lot of, we have a big prison population that we have to see, and those transportation costs with their officers coming with them and the wait time and all those types of logistics cost the health system a lot of money, and us taxpayers are paying for that. So anytime we can help alleviate that process and that burden on the health system and the taxpayers, then we're winning. We'll go to patients who make very bizarre sacrifices for telemedicine. So I'm sure that a lot of people have polled their own patients and seen that patients really want this kind of service. And so much so that they'll make really bizarre, sacrifices for it. There was a recent Harris poll and FICO survey that showed that over 80% of patients want to use their mobile devices to interact with their own doctors. And this is their own doctors, not an online service where they don't know the doctor, they don't even know if it is a real doctor, and they have no continuity of care. So for their own doctors, over 80% wanted to be able to have that kind of access, and they were willing to make sacrifices for it. What sort of sacrifices, you might ask? 13% said they'd give up shopping for a month, 9% said they'd forego their next vacation, 5% said they'd skip showers for a week, and 3% said they'd actually forfeit a salary increase. And that's how much our patients really want to have telemedicine access. I really like this picture from the Jetsons. I don't know if anybody remembers this cartoon, but back when I was a kid, you know, it was kind of all the rage. And I thought this was excellent because they're actually showing a telemedicine visit here in this cartoon. You can see the doctor is examining the kid's throat through the monitor. And that was, you know, one of the first times telemedicine was alluded to. So what are the best patient use cases for telemedicine? This is probably the time when I like to say that, you know, giving people telemedicine is kind of like giving people fire, like Prometheus coming down from Mount Olympus and giving people fire. You know, you can do anything you want with it. There are a million different use cases. With fire, you can warm your food, you can cook your food, you can have light, you can have heat. It's the same kind of thing with these telemedicine tools. There are a million use cases, and you know, if you ask 100 doctors, you know, you'll get 100 different answers for it. But I'll tell you what really works for my practice and what I've seen work in the best practices for which Everbridge can attest. So in consults are very important. I mean, this whole thing started when I was trying to do ER consults from my office while seeing patients. I'll tell you a story about the inception of the HIPAA Bridge app. One day I was in my office and seeing patients. The ER doctor called because I was on call, and he said, "Dr. Habash, we have an orbital fracture here. You need to come down right away and evaluate for surgery." And I said, "Well, there are 20 patients in my waiting room, so why don't you just text me a picture of the CT scan?" He did. And then I said, "Okay, I need a 30-second video call with the patient." So we did a quick FaceTime call with the patient. And 30 seconds later had ascertained that patient didn't need surgery and could come follow up the next day. Hung up my cell phone, went about my business, and I got in trouble for that by our compliance officer at the hospital. The reason was that it wasn't compliant video or text communications. And I said, I don't understand the problem because I was happy, the ER doctor was happy, the patient was happy, and the 20 patients in my waiting room were really happy. So I didn't understand the problem. The problem, of course, is compliance. It's a compliance issue and HIPAA compliance issue. And that's very important because we have to protect our patients and protect their privacy, also protecting ourselves in the process. Well, I could see then that there was a very big need for some sort of streamlined communication within the medical system, and I had my brother, who was a Microsoft engineer, write me medical software that mimicked iMessage and FaceTime, but made it HIPAA compliant. And my one caveat to my younger brother was, if it takes me more than one brain cell to use, I'm not going to use it, and neither will anyone else. And it spread virally from there because he delivered, and he made it exactly, you know, the same look and feel as what we always all do on our phones every day and what we're used to doing, but he made it HIPAA compliant. And, you know, there we had an amazing tool by which to communicate with patients and amongst our colleagues. That's how HIPAA Chat was born, or HIPAA Bridge, which is the offering now from Everbridge. So for consults, you know, it's invaluable for this reason. There are so many times when patients wake up in the morning and they have an issue, an acute issue, and they call the office or they try to go to the ER, and they would love someone who knows them to be able to triage that complaint right away. Sometimes the answer may be, no, you have to come into the office or you have to go to the ER. But fine, you know, at least you've given that patient an answer that they can rely on. Many, many other times you have to just call them something in, or they can come in the next day or whatnot, and it's so much more convenient for them. For patient follow-ups, I find that this is also very, very helpful for my practice. As an ophthalmologist, there are so many cases where I have a patient with conjunctivitis or a sty or something like that, and they need to come back in a week, but they're feeling better, and so I give them the option of doing an e-visit at that time. And so my office will have them just download the HIPAA Bridge app from the App Store or Google Play, and my office communicates with them that way. We end up doing a video call, and I'll go into the logistics about how to schedule this and how to kind of integrate it into your practice a little bit later on. But for follow-ups, it's excellent because there's so many, you know, young professionals out there who don't want to take time off work for a simple issue and come sit in my waiting room or sit through traffic or whatever, or patients who don't want to get a babysitter for the afternoon or can't leave their kids, things like that, where you're really giving them such a great convenience while giving them the ability to see their own doctors who they trust and love and who know them. So follow-ups are a very, very important use case. Patient check-ins like mental health and wellness checks are actually a very important use case as well. Behavioral health is one of the biggest use cases for telemedicine in the literature these days, and the reason is patients with behavioral health issues feel more comfortable in their own environments. And so when they're not being asked to leave their own environments, they can be more real, more honest about their feelings and how they're doing. And so behavioral health specialists find this is very important to check in on patients, to see what their mood is like, to see if they've been taking their medications, to see how they're acting on video, what their motions are, what their movements are, what their affect is, which is how their faces look. And those are things that are really important for behavioral health. Patient transfers are very near and dear to my heart because at Bascom Palmer, which is the #1 eye hospital in the world, we get so many patient transfers, and those transfers cost the hospital a lot of money. They cost the transferring facility a lot of money, and oftentimes they are unwarranted. The flip side is also true. Many times there are patients who really need to be transferred who aren't, or who are held up by the process and lose very valuable time. So, right now we triage patients on the phone and we don't really know what's going on, and that's just not a good situation for anyone. So when I can use HIPAA Bridge to communicate and do a video call with that transferring facility, and we're getting all the facts, we're getting all the information, and we're able to start orders or to triage that patient much more effectively. So it saves the health system so much more money, and of course it's so much better patient care. For patient monitoring like chronic conditions, clinical trials, during diagnostics, Medicare and some of the other insurances are now reimbursing for chronic maintenance and chronic conditions. They're paying on outcome versus the work done. And so telemedicine becomes a very important tool for those use cases. Spent a lot of time on that slide, but it was important. So let's go to the next one. These are just more fun facts. I think it's interesting because Lisa took a poll a little bit earlier to see how many people are using telemedicine, and it's 59%, which is pretty good, actually. The percentage of providers that have telemedicine programs in hospitals is 72%, and in physician groups is 52%. So if we're talking to a bunch of physicians here, or physician groups, then we're pretty much on target. Employers are now offering telemedicine benefits as well, and that's gone up from 2015 to 2016, about 30%, because employers are finding that they don't want their employees leaving work for extended amounts of time or missing work when there are things that can be dealt with right at the desk, or right at the cubicle, or right in the office. And so employers are saving a lot of money and keeping their employees more healthy and keeping them from losing time at work. So these are just some reimbursement and private payer facts that I thought everyone should know. This is kind of, a very meaty slide. Telemedicine parity laws, in case you're not sure what that is, if your state has a parity law, then it simply means that the private payers must reimburse you for telemedicine visits. Right now, 32 states plus DC have parity laws, and 8 more have proposed laws, which means they'll take effect within the next couple of years. And that's great. And it's kind of like the floodgates are open now, and more states are coming on board. So it's becoming a much more, accepted and widespread issue. The big 5 private payers cover telemedicine. That's Blue Cross, Cigna, Aetna, Humana, and United Healthcare. Those are great, and I've billed all of them and been reimbursed by all of them. Medicare is a different issue. The patient has to be in in a very rural area for them to cover at this point, unless it's a chronic care management issue. But that will be changing very, very soon. One of the things that you should do is verify telemedicine coverage by calling your payer directly. So in my office, for instance, we call the patient's insurance to check all their benefits, not just telemedicine, but it's just one of the things on the checklist. So it's very easy. It takes no extra time. Live video telemedicine is the covered service, and this is very important because you can't do a telephone call and call it telemedicine. You also can't just text pictures back and forth with your patient and call that telemedicine. The strict definition of telemedicine and telehealth is live real-time video. This is not store and forward recorded video. This is actual FaceTime-like video that's HIPAA compliant. Reimbursement is for any E&M service, and that's including new patient and consult codes, mental health, and chronic care. So I'll go into it a little bit further, but there's no change in the billing either. I mean, it's just your normal E&M code, whatever you normally would bill for any patient. You just use a certain modifier, and that modifier is the GT modifier, and that tells the insurance company that that was an electronic visit. Patient can be anywhere when they're doing this. They can be home, work, school, in their car, and you'll get reimbursed 100% of that code, exactly the same as an in-person visit. All right, this is kind of an introduction to HIPAA Bridge, which is the secure messaging and video component from Everbridge. It offers HIPAA-compliant texting and telemedicine, video calls, which are exactly like FaceTime, a walkie-talkie that's great for dictation purposes, and of course you can have group messages as well, because the care team being involved is very important. As an ophthalmologist, I'm usually one of the last people being called in on a case, and it's very difficult to sift through the chart and figure out what's been going on with the patient. But when I'm added to a HIPAA Bridge group, I can see the entire preceding conversation and catch up on what's been going on with that patient very quickly. So I hear this all the time from my colleagues. Ever wish you could just use your phone? Well, now you can, and that's what Everbridge is offering. So I wanted to touch a little bit on the Mayo Clinic stroke team case study that we did, and I think Eric Chetwynd will be elaborating on this a little bit, but I'll give you an overview. I had read a statistic that 85% of patients who go to the ER are never admitted to the ER or to the hospital. And why is that? It's because when they get picked up from the ambulance, they really just needed help getting off the toilet or figuring out what medicine to take next, or some other issue that really didn't warrant admission into the hospital. And so you've got all these patients who are using ambulance services and costing taxpayers a lot of money for non-emergent services. Meanwhile, the flip side is that patients who really need those services are not getting the benefit. Those ambulances and that staff and those paramedics are being taken up by non-emergent issues rather than being able to be available for things that are really important, like acute heart attacks or MIs, and stroke patients. Stroke patients are probably the most critical of the bunch, and that's why it occurred to us that maybe we should approach the #1 hospital in the country, which is Mayo Clinic, with their sickest patients, which are the stroke patients, and see if we could make things happen there. And we did. So the study was set up as follows. We did a feasibility study to see if triaging a stroke patient while they're still in the ambulance is even possible. Turns out it is. So what we ended up doing was we had the neurologist from Mayo Clinic conduct the NIH stroke scale, which is essentially a questionnaire and physical exam, while the patient was still in transit. So this saved a lot of money and time and care for the patient. And let me just elaborate a little bit more on what usually happens. Usually the patient has the ambulance called. They are in transit to the hospital. When the patient finally gets there, they call in the neurologist, who eventually comes to see the patient, who does the NIH stroke assessment, and then makes decisions about what needs to be done. With stroke patients, you have about 90 minutes in order to treat them so that they don't lose, brain cells. And in neurology, we say, time is brain, which means that every minute that patient is not getting intervention, they're losing about 1.8 million brain cells. And that's the difference between walking out of the hospital and being wheeled out. And so it's really important. Every minute counts for these patients. So if you can triage them from the ambulance, you're saving a lot of time. In fact, what we ended up doing was saving about 7.45 minutes. Multiply that times 1.8 million brain cells, and look what you've done. We were able to save that time that's called the door to needle time. That's door to, by the time the patient walks through the door till the time they get their intervention. It may not seem like a big number, but that's a very big, significant number in neurology. It also, because we were able to get treatment faster, it decreased the hospital length of stay and the complications that the patients had. And the cost savings was magnificent. So compared to a $1.5 million mobile stroke unit, our setup was about $285. And that's because we had a license for HIPAA Bridge on an iPad mini, and that was it. And there was zero support needed because it was such a simple app and a simple way to do things. So we simply had the paramedic on the ambulance, with an iPad mini with our app on it and communicating with the neurologist at Mayo Clinic, who was also on the app at the same time. So imagine those cost savings. So not only do we save costs, but even more importantly, we save lives and brain cells, and that's priceless. We can go to the next slide, and Eric, I'll have you take over here.
Okay, thank you, Dr. Habash. And I'm just going to extend out a little bit about what Dr. Habash is speaking to with the Mayo Clinic stroke study. And in our example here, we have represented Mark, who's our paramedic. So think of him as, he's on the ambulance with our patient, in this case, Mr. Thomas. And he's able actually to communicate directly into the ED in this case and say, I have a possible stroke patient, and our triage nurse in this case can respond directly. And one of the things we can do across the platform that Dr. Habash has been speaking to is we can then call for a stroke code and really reach out and figure out not only being able to connect, in our case, the neurologist, but figure out who is the on-call neurologist, look at schedules, get the communication out, make sure that person confirms that they're available. In this case, Dr. Adams responds across the platform saying, I'm ready to engage with that patient. He then reaches out to Mark. We're in this group conversation that Dr. Habash was speaking to, and actually calls for a video consult. So very quick response to be able to get our on-call neurologist, I think, is one of the key challenges for many emergency departments today is having enough on-call staff. And so many of them are working remotely. That's particularly true with neurologists across the country. We're able to conduct a video consult, basically do the stroke assessment and say we're going to fast track, in this case, Mr. Thomas, straight to the radiology for a CT scan to take a deeper dive when he arrives. We call for a fast track, and our team responds directly within the ED. We have our on-call duty tech, our on-duty tech down in radiology, and Sally, our ED nurse, is going to escort Mr. Thomas in. Next, we get our response from George, our on-duty tech, right across the platform, saying he's ready, and of course the ambulance arrives, and Sally meets the ambulance right at the door. And we're now also able to post up, and this speaks to some of not only doing the video piece, but we're actually able to share up the CT scan in this case directly into the conversation, so that Dr. Adams, again, who is working remotely in our scenario, can do the assessment and make the call about, in this case, administering TPA. And this ties into, and then that's administered by the nurse who's right there. So that's one way that the whole platform comes together, and you can leverage all the key components that Dr. Habash has been speaking to. And as she mentioned, in this particular case, there was 7.5 minutes nearly saved, which not only leads to a better outcome for that patient, but obviously can significantly impact costs both to a hospital and increasingly with the introduction of value-based care into hospital settings, not just the hospital stay, but the downstream rehab costs that may be incurred by that particular patient. And so this just highlights that, this is one scenario, but I think particularly when you look at emergent cases, we have similar situations for patients who are having heart attacks and maybe having a STEMI, where that door-to-balloon time is significant. Also, we have, as Dr. Habash highlighted, transfers, right? So this, in the case of the Mayo Clinic, our patient probably does, we do want that patient going to the ED, but if it's a smaller setting, we may want to transfer that patient to an academic center that has in this case, a stroke center available as we're making that call. And it's really about doing all that as quickly as possible, leveraging the technology we have today, because I think, as everyone knows, every minute in these really high emerging cases has significant impact on the outcome of those patients, and that's really the benefit of it. But in addition to that, it not only applies to emerging cases, but really we're doing a lot of work with hospital settings and ED settings where it applies to non-emerging cases as well. And so when you think about things like having consults for lower acuity cases, urologists and other folks who are coming in for maybe not something that's life-threatening, but still requires that quick consult, it still can have a significant impact on the workflow within the emergency department. And that impact not only streamlines the process within an emergency department by getting those consults in faster, allowing the team to basically communicate faster, but can impact on throughput, reducing average length of stay in your emergency department, which leads to less diversion and patients left with not leaving without being seen. And so those patients would normally be, obviously they're going home without care and left without being seen case and maybe waiting a while. And or it can drive, those are also revenue opportunities in the case of a hospital, but also patient opportunities, the opportunity for a physician who's doing consult to really engage a new patient and provide that longer term care. And with that, I'm going to turn it over to Dr. Habash just to speak about, as those new patients come on board, what the reimbursement coding is for those patients.
Of course. Thank you, Eric. So kind of like I covered before, I mean, billing is super easy. And so that's important because our offices already have to deal with enough paperwork and, regulations. And so we don't want to make things harder than they need to be. And this is really a simple thing to add into your practice. You don't have to bill anything different from what you normally do. It's just the E&M code, whichever one you want to choose. Use the same guidelines that you already do for a face-to-face visit. And just put a GT modifier on the end of it. That's what tells the insurance company that it was an e-visit. And again, just remember that it has to be a real-time video call that's HIPAA compliant. It can't be FaceTime or Skype. Those are not HIPAA compliant. And it can't be a telephone call or texting. It has to be that real-time video, which is what HIPAA Bridge offers. So eligible providers who can bill. It's not just the physician. It's a nurse practitioner, a PA, a nurse midwife, clinical nurse specialist, or any registered dietitian or nutrition professional. So think about all the diabetics who are getting counseling out there. Diabetic management is a very well-paid code in medicine, and when you have a registered dietitian or nurse doing those types of screenings and assessments and giving that kind of management, you're making a lot of money for your practice and for your institution. Eligible facilities, the office of a physician or practitioner, any hospital, rural health clinics, any qualified health center, and that's something that it's a certification that you can get for any health center. A skilled nursing facility, hospital-based dialysis center, and community mental health center. How do you roll it out in your practice? This is probably the hardest thing, just because everyone has a different workflow in their office and in their institution. I can tell you what works for me and also what works for some of our best practices. For me, it's very simple. It starts with putting an announcement in the patient registration form and putting announcements around the office, even emailing my patients. And my announcement is a very happy one. It says, "Congratulations, your doctor now offers telemedicine." This means that for many cases, you won't have to leave work or leave home in order to see your doctor. And it's covered by, it's covered by insurance, and they love that. Patients get very excited when they read that announcement. So it's one of those things that I introduce at the start in my practice, and it follows the patient through. So I just have them download the free app on the App Store or Google Play. There's also a desktop version, and all my patients are kind of armed with that app. So when they need assistance, I have them call my office just like they normally would. They wake up in the morning with a swollen or bloody eye and they don't know what to do. They call my office just like they normally do. But hey, now we've got the ability to jump on a video call with me, and I get to triage them within 30 seconds and tell them what they need to do. It's either I can call you something in, or you need to come into the office or go to the ER, but at least they're seeing me and I'm giving them an answer that they can trust. And I can trust what I'm seeing, too, because I'm not relying on it secondhand from a telephone call. So that's one of the first places I start. For follow-up patients, like I was saying, at the time of the visit, when I see and I can identify that there's a patient who would benefit from an e-visit, I offer that to them. It's not often that patients say they'd rather come into the office, believe me. They'd much rather sit at home or sit in their office and in their own office and be able to do a visit. And so I offer it to them at the time of that visit. If they opt to do it, when they go to the front desk to check out, just like we schedule a normal visit, we schedule them for an e-visit, 1 week down the road or whatever. I've got a special color in my EMR system and a special time allotment of 5 minutes, because that's, really don't ever need more than about 5 minutes to do these visits. Usually I try to stack them at one part of the day or whatnot, but my staff knows that in between patients, if there's an acute issue, they can always grab me. And it's so quick and simple to do. Everyone's happy, and I get to bill for it, which is great because we were doing all the work before, but not billing for it. And we deserve to get compensated for that kind of time and effort. So that's pretty much how I roll it out, and that's how I kind of, when I'm implementing offices and hospital systems to do this, that's kind of what I tell them to do. Again, everyone is going to have a slightly different workflow, but that's the general way to do it. You just educate your patients, you educate your staff, you have everyone armed with the app, and then there are usually no barriers to that kind of adoption. Of course, the provider has to make the final call as to whether or not that patient is amenable for an e-visit. As far as the billing goes, when I see a patient or when we do the follow-up visit, for instance, an encounter is put in my EMR system, which generates a fee ticket, which is then sent out to our billing company. And we code the fee ticket exactly the same way with an E&M code and a GT modifier on it. I can tell you we get reimbursed 100% of that E&M code for almost every instance. There, of course, are always exceptions, certain insurance plans or whatnot, but it's very few and far between. If anybody has questions, I'm sure Lisa's getting them and we'll be able to answer them at the end of this. What do patients like about telemedicine? It should really be, what do patients not like about telemedicine? Because I really haven't had too many complaints at all. They save time. They don't have to drive in and sit in traffic. They don't have to get a babysitter. They don't have to lose time off work. They don't have to sit in my waiting room for an hour or go through the Bascom Palmer process to get seen. And they still get excellent care. And I think the important thing to note here is that I'm a big fan of doctors seeing their own patients. I don't want my patients calling, Dell tech support like places to get a clinical opinion, because I don't know who they're talking to and they don't know who they're talking to, and there's no continuity of care, and there's no access to the records in almost every single case. And so because of that, I just don't think that's good patient care. I would much rather keep my patients in my own system, and they would much rather be seen by me or by someone that I trust in my staff than go somewhere else. So I think it's a win-win all across the board. How do I track telemedicine visits in my EHR? So this is kind of what I touched on before. I just enter the encounter exactly like I normally would. Oftentimes, let's say a patient has shingles or pink eye or something like that, or rash, I'll have them take a picture through the HIPAA Bridge app, and I will put that in my EMR system on their visit as extra documentation. That's certainly not a requirement at all, but I like to have it. And it's so simple and easy that, why wouldn't you? So that's I just document in the EMR system exactly like I would for a normal face-to-face visit. My staff does the chief complaint, the history of present illness, and takes all the kind of, the screening questions just like they do for an in-person visit. I do the exam and then document my findings and treatment plan. We're done. It's a very quick, simple process. How does malpractice and telemedicine work? I have yet to find a malpractice insurance that doesn't cover telemedicine. I'm sure there's some out there, but I've checked with all the major coverage companies, and there's no one yet who says that they don't cover it. And trust me, if they don't cover it at this point, or if there's a premium for it, it won't be for very long, because you're seeing now that more than 50% of offices and 72% of hospitals are offering telemedicine. It's a no-brainer. We all know that it saves costs for the health system and it's better patient care. And so for those few people, few payers who aren't paying right now, or malpractice insurances that aren't covering, then, it won't be for long. But again, just to reiterate, my due diligence is to check with, almost every malpractice carrier to make sure they're covering. And, from what I found and from what the American Telemedicine Association statistics show, there really aren't any malpractice insurers that aren't covering telemedicine. Okay, we can go to the next slide. Okay, I wanted to end on a really funny slide. Use telemedicine because only actors smile in waiting rooms. And I can tell you my office is pretty awesome, but my patients do not look like this when they're sitting out there. And I doubt most of them do. So anyway, I think this is a cute slide to end on. So I'm pretty sure we must have a lot of questions coming in. Lisa?
Hello. Thank you, everyone, for staying with us. It has been such a good webinar, Dr. Habash. Thank you so much for sharing your information, and Eric for taking us through the process. We definitely have some questions. So the first question I have is, how do paramedics have time to do video when they are caring for the patient in the ambulance?
So I think that's a very good question. So part of the NIH stroke scale is to identify all the stroke components. So for instance, when a paramedic is in transit, they're already doing that same assessment. It's just that the neurologist isn't seeing the results of that and is not performing that assessment himself. So the paramedics are already doing the same work. It's just now they're being videotaped while they're doing it, and the neurologist is getting the information real time.
Great, thank you very much. And then I have a very specific ophthalmology question for you. Can you speak about telemedicine for ophthalmology fundus photography and the billing codes 92250 versus the retina screening code 92227?
Wow, okay. Yes, absolutely. For teleretina, which is what that's called, we have, there are a host of non-mydriatic cameras out there, which will take an image of the fundus and send it to an ophthalmologist. So if the ophthalmologist is doing the read, even though the technology is not in that ophthalmologist's office, you can actually bill a 92250, which in most cases will pay about $75. The 92227, which is a diabetic screening, I'm not as familiar with because, we at Bascom Palmer, we do our own reads. We have a retina specialist who's reading these teleretina images that come in. Is that helpful?
Yes, thank you very much. And then I do have some questions sort of about how you set up your practice. So, for instance, how do you set up telemedicine within your practice? And then I do have a specific request for what EMR system you use.
Sure. Okay. So we work with a lot of different EMR systems because I have call obligations at a lot of different hospitals, and of course none of them are on the same system. But I'm very familiar with Epic and NextGen particularly. So. We have, I guess this might be a good place to say that, HIPAA Bridge and Everbridge suite in general has many other offerings, and we have open APIs, and we often do interfacing with other systems. But I have chosen not to do that in my own practice, for instance, because I think that it takes out some of the simplicity. And the beauty of the app and the convenience is in its simplicity. And so I input information into the EMR system in Epic and NextGen exactly the same way I do when I'm seeing a patient face-to-face. Again, my technicians or my MAs will screen the patient and do all the pertinent history and the preliminary stuff. And then when I come in to do the examination, I document what I need to and the treatment plan as well into the EMR system. You obviously can't do a full exam because the patient is sitting right in front of you, but there are so many conditions that you can treat so easily: rashes, zoster or shingles, styes, conjunctivitis. There's so many different things, and then many times there are just simple things that I need to go over, like lab results or pathology results, things that really should be communicated face to face, and by face to face I mean video as well. And so those are all very easy and convenient things to do for the patient.
Okay, and we do have time for one last question. And the last question that we have for you today, Dr. Habash, is what steps do you take to onboard your existing patients into telemed, and how do you market those new services?
So kind of like I was saying before, I have an announcement in my patient registration form. And again, the announcement is a very positive, exciting announcement because it's a very, positive, exciting service. And you want to get your patients excited about it. And so I have it in all of my patient registration forms for new patients. The existing patients, I have pamphlets laying around my office. I've created kind of marketing materials, download instructions, which are really simple. I tell patients very plainly, it's kind of like, downloading Candy Crush. It takes about 2 minutes to get up and running, which is really simple. And in my practice, I have so many patients who are older, 90 years old or whatnot. And, if my patient population can do it, anyone can, because these patients are older and they're not used to technology yet. You will see them sitting in the exam room with their iPad, FaceTiming their grandkids or having their family on a call while we're doing the exam. That's more my bokeh patients. And that's okay because, that's the way things are headed in medicine these days. So, if they can adopt it and they can embrace it, then really any patient population can.
Great. Dr. Habash, thank you so much for your time today. Eric, thank you so much for your time as well. If anyone has any additional questions for Everbridge and how HIPAA can integrate into your practice, we would be more than happy to talk about it. HIPAA is just one part of our clinical suite. We also have templates and IT alerting for hospitals and security measures for patients. There's a whole array of products available to you. We would be happy to talk to you about it. Please feel free to contact us or email me specifically, lisa.johnson@everbridge.com. We will be doing more clinical webinars in the future. We look forward to seeing everyone soon. And one final reminder, we will be sending out the slides and a recording of the webinar early next week.